It's a pleasure to be here today, and thank you again for inviting me. I'm going to try to keep this very practical and how we've applied protons at the University of Pennsylvania and also what the experience has been globally with protons. And you've heard some really great introductions this morning, and I won't reiterate those points. I'm going to try to take them into the nature of how I apply that towards patients. I just wanted to take a moment just to tell you about Penn Medicine. You may not know the University of Pennsylvania. It is a large academic institution in the US. Just the medical portion of this has about 51,000 employees in that group, and we have about 4,700 employees in the School of Medicine itself, and about over 2,000 faculty in the School of Medicine at Penn. And our mission really goes around classic things which you have: excellent patient care, innovative education, research. And our research at Penn is a little bit different. We focus on really a lot of translational research, taking that from the lab into the patient. I'll highlight that in a moment. And really community service around our region with vulnerable populations. So discovery science is really important at the University of Pennsylvania. We actually get about $1 billion in US dollars in funding per year through the National Institutes of Health. We really focus on research and clinical trials. We have about 4,500 clinical trials at any one time. Importantly, over the last 12 years, we've actually had 41 different things, whether that's equipment or drugs, go to FDA approval in the United States that were developed at the University of Pennsylvania. Our team developed CAR T cells at Penn, Dr. Carl June. Our team, two of our team members, Drew Weissman and Katie Carrico, won the Nobel Prize a couple years ago for developing mRNA technology, which, as you know, was used in the COVID vaccines and other places. And we've done the first gene therapy in the United States. That's kind of the area, the space we like to be in. And we've had a lot of firsts with proton therapy at the University of Pennsylvania. We actually have the largest proton center in the world. It remains that. It was built in 2010, remains the largest center in the world with 5 treatment rooms for patients and a research room. We were the first center in the world with what we call gantry rolling floors. Used to be patients hung out on a gantry out over a pit that was 10 feet deep, which was a little crazy. We built floors that went around the gantry. Now every facility in the world has that. We were the first one to actually do large-scale pencil beam scanning, so really put it in the clinic and do high-volume pencil beam scanning with our patients. We were the first ones to do soft tissue imaging or bring the cone beam CT into the proton environment, which you've already heard about the issues of positioning, weight loss, motion. Those are all critical issues in proton, so having soft tissue imaging was critical. We developed what's called the first hub and spoke model of proton therapy. We now have 3 active proton centers, and I'll get into that in a few minutes. We're building our 4th center right now. And we were the first to develop proton flash radiation and publish the first proton flash papers out there in manuscripts. And we'll talk about that a little later this afternoon, because we are a leading facility in that development. And we were the first to deliver conformal flash treatments. So my radiation oncology department is relatively large. We're the largest academic department in the United States. We have 17 sites of care. As you heard earlier, we have 37 linear accelerators. We have Gamma Knife, CyberKnife, tomotherapy. We're building our 4th proton center. We treat about 12,000 new patients per year in our sites specifically. We treat about 10% of that receive protons. So protons are important, but I hope you understand by the end of this, protons are an important tool in the toolbox for some patients, not for every patient. Conventional radiation is important. It's not going to go away with protons, but protons offer better care for certain patients out there, and we'll talk about that today. You've seen this slide already, but with the Bragg peak, but the way I talk to people about it and keeping it practical, what's the difference between protons and photons? It's pretty easy. Photons go in one side of the body and go out the other side of the body and treat everything in between. That's why I can put an X-ray film behind someone and get an X-ray image. Protons are different. They enter the body at a lower dose, they release all their energy at a point that I prescribe, and they stop. So there's 0 radiation beyond the target and much less in front of the target. So it allows me to reduce side effects of many important organs giving less dose. And that's particularly important when we look at combining protons with chemotherapy and biologics that may sensitize those tissues to radiation. So it becomes critically important in that area. Also allows me to dose escalate, give higher doses of certain things, treat next to critical organs where I couldn't before. So practically it offers me other opportunities for treatment of patients. So what's going on? Well, in the United States, there are currently 45 proton treatment centers around the US. There's about 13 others that are under construction or being planned in the next 5 years. I can take that same map and overlay that with Europe or overlay it with Asia. It's virtually the same. There's about the same amount of centers in North America, Asia, and Europe. So proton therapy is not just coming, it's here, and it's growing actually very rapidly. So the Perelman Center for Advanced Medicine, that's where our main proton center is, and we have 5 linear accelerators on that site too. So I treat about 100 patients a day with protons, about 150 patients a day with photons on that specific site. All patients are treated with pencil beam scanning. You heard about different types of protons. Pencil beam scanning is what we use, and I'll show you an image of that in just a few minutes. And we use a single treatment planning system. It's Variant Eclipse across all of our centers. Everyone always asks me, what is our patient mix? When we started in 2010, our mix was small. We started with prostate cancer because it was simple. We wanted to learn how to do it and not make mistakes. Then we added CNS tumors, which are in the brain is relatively simple. Then we slowly expanded over a few years to all disease sites. The way we work in our department, I specialize in gastrointestinal tumors. I have people that specialize in pediatrics, lung tumors, whatever that may be. All of my team does protons. It is just another tool. They do photons, they do IMRT, they do brachytherapy, and they do protons. So we don't have a proton team and a photon team. We have a team that treats with all modalities and tries to pick what is right for that patient in front of me. So our mix, you can see, is pretty broad. 20% is pediatrics. And why is it pediatrics? Well, at our center, Children's Hospital of Philadelphia, CHOP, owns 20% of our proton center. They actually manage to that amount of patients in there, so we treat about 20% of our volume pediatrics. The rest is a pretty big balance between thoracic, head and neck, GU, brain tumors, GI. Now, what's emerged in the past few years, very importantly, is reirradiation. So patients that have gotten radiation before that you usually wouldn't treat again because of the risks of the normal tissues, those rules completely change with proton therapy. Because if I can miss the normal tissues, spare normal tissues from certain directions, I can give radiation again where I couldn't before. And we'll talk about that in a few minutes. At our center, it's about 20% of what we treat. At some centers, it's up to 50% of what places are treating. So it's become a big part of patients we treat today. And that's important because what's happening in the world outside of radiation we have to think about. Immunotherapy. Immunotherapy is changing the lifespan of our patients. They're living longer. They're developing metastatic lesions. And immunotherapy works well, for instance, at microscopic disease and controlling microscopic tumors. It doesn't work as well at controlling a lump of tumor. And that's where we're coming back in with radiation. It's the same with protons and local recurrences. If we're controlling micrometastatic disease, local control becomes more important. We're seeing more of those patients than we ever had before with the advent of better systemic therapies going forward. So just to give you some images, what does what our proton center looks like specifically? This is a patient room. This is the gantry itself. You can see the table, the patient couch the patient lies on. You can see the nozzle where the beam comes out. That structure rotates 360 degrees around the patient, so we can treat from every direction. We have imagers that come out of the back of the wall for cone beam CT that can rotate around the patient. We can get specific imaging every day. Now, I look at the glass around that. We are on the second story of a third story structure that's rotating around the patient. So this gantry structure weighs about 100 tons and rotates to within 1/10 of a millimeter of accuracy. So it's a pretty amazing engineering feat. And I'll give you a better image of that in just a moment. So we have a cyclotron. You heard you could use synchrotrons, you can use cyclotrons, you can use synchrocyclotrons. These are all ways to accelerate protons to basically 2/3 the speed of light, 230 million electron volts. And in a cyclotron, it's two magnets, two big magnets. We're injecting protons in the center of that magnet. As it gets more and more radius, it gets more and more energy. It gets up to 230 million electron volts, then goes down that beam line. In a cyclotron, it comes out at the highest energy, and we use something called a degrader that reduces that energy down to whatever you want for that specific patient, because that determines the depth of penetration in tissue. Synchrotrons are different. You can select the energy. So they're just different systems to deliver protons. This is one of our gantries before it was shipped to the United States back in this is probably 2008, 2007. So to give you an idea, if you look in that left bottom corner, those are people standing down there. So when we built these centers, you had to build the foundation of the building, bring the equipment in, then build the rest of the building around it. So that's part of the cost of these facilities. It's not just the proton equipment. The cost is extraordinarily high because the buildings you have to build around them with 9 feet thick of concrete or 3 meters of concrete around this. You can imagine that scale. It's a very, very big building, particularly at multiple rooms. And when we built our first center at the University of Pennsylvania, it was only set up for multi-room centers. We couldn't select a single-room center like you could today. So our center has a single cyclotron, 5 treatment rooms, and then a 6th room where we just do research in that room going forward. So a very large center. And that's changed. So today, this is a single-room system from IBA. On the left, you saw some images already. These are much smaller systems. But you give up some compromises in a smaller system. One, the cost. It is cheaper. The buildings are cheaper to build. The rotation is not 360 degrees around the patient anymore. It's 230, and you rotate the couch. So instead of rotating the gantry the full spectrum around the patient, you rotate the couch halfway through treatment if you want to treat the other side. But you can see in this corner here, the size is smaller. And I think importantly, and I do recommend anyone that builds a proton therapy center, think very carefully how you integrate protons with your other cancer services. In the United States, we actually had some facilities that got into financial trouble. They weren't making the money they should. Why was that? Well, it was because they built them the wrong way. They built proton centers by themselves in an industrial park, as opposed to building it on a medical campus with all other treatments there. And they didn't get the same number of patients. And it turns out, and I'll show you some data in a minute, when you build protons, the halo effect, the effect on all your other cancer services goes way up. So your photon volume goes up, your chemotherapy volume goes up, your surgical volume goes up, because it becomes a big flag that people see, and they come in for protons, and that might not be the right therapy for them, but they stay for other treatments. So this has been shown time and time again. The halo effect of protons is actually really important to understand on your other cancer services when you build a proton center. So this is what we were doing. This is a little movie. We take a tumor now. This is obviously a cartoon. We divide it up voxel by voxel in 5 millimeter cubed areas, and we take this pencil beam, and we treat spot by spot, layer by layer, changing the energy, and I can step back a layer with each energy change. And I can give a perfectly conformal dose to this target. And it can be a very, very complicated target. So similar to IMRT, right? So really it's very similar to that. When you heard about passive scattering earlier, the problem was we couldn't have the same kind of conformality that we had with IMRT. We converted to IMPT many years ago at Penn, and this is the type of thing we can do with that, with no dose beyond the target, much less in front of the target, which gives us a lot of opportunities to treat very, very complicated things. So when we started, you saw the data is starting to emerge. When we started treating, we actually signed our contract and started building our center in 2006. We were the 4th center in the United States to be built. There was not a lot of data. It was an FDA-approved technology in the US, so it could be investigational in the US, and we could use it with a lot of ways. We got very creative. In the United States, we have a different kind of payment system. There's a government payment system, and there's a payer system, commercial payer system. We partnered with our commercial payers to develop evidence. So the commercial payers paid the same as IMRT for protons during evidence development. We were able to get the patients on treatment, do clinical trials, and generate data, which has been really important. And that's worked out actually well for us at Penn. We saw early on that this issue of combined modality therapy, when we treat patients with combined modality therapy, we know there's great data out there, concurrent chemotherapy and radiation. Patients do better in regard to organ preservation. They do better in regards to survival. However, it's always at the expense of increased toxicities. So we're very careful when we pick our patients. We're not generally picking patients that have high morbidities or other diseases or are older. We're picking the fittest of patients to get through that because we know they're going to get some toxicity. Well, we hypothesized at Penn, well, if we're giving less dose to normal tissues, when we give protons compared to conventional radiation, we may see reduced toxicity. So what do we find? And we actually published this data in JAMA, the Journal of the American Medical Association. But it's tough to see, it's small, but what it shows is we looked at hospitalization rates during the 90 days from the start of radiation to 90 days after radiation's completed. And we looked at grade 3 toxicity and hospitalization rates. It turns out when we gave concurrent chemotherapy with photons, our hospitalization rate during that time was about 29%. All patients included, all disease sites. When we used protons instead of photons, our hospitalization rate was 9%. So significantly reduced hospitalization rate. Now, in the United States at this time, when we did the study, one of the issues was Medicare, which pays for patients over 65 in the United States for treatment, covered protons. So we get protons for all the older patients. I couldn't get it for all the younger patients. So the patients that got protons were 6 years older and had significantly more comorbidities than the other patients, and they did way better because of less toxicity. And I can see it. I can look down the hallway. When I have a patient coming down the hallway, if they're getting chemotherapy and protons or chemotherapy and photons, they just sail through treatment with protons. They just feel better on a daily basis and get through easier. And what about the published prospective randomized proton therapy trials so far? That's it. There are none yet, but they're coming. They're coming. So the first trial with head and neck cancer you've heard about already. It's been I'm going to show you some data on that coming up. It's been an abstract form only. It's actually been accepted in Lancet, and it's going to be coming out any day now. So there are survival benefits and reduced toxicity that we're seeing in head and neck cancer for sure. There's numerous trials that have gone on for lung cancer, esophageal cancer, liver tumor, brain tumors that have been closed or are still accruing. There's some important pragmatic trials. In a large trial that we ran out of the University of Pennsylvania for breast cancer called RADCOMP, just completed last year with about 1,200 patients. That has been completed. It's going to take 5 to 10 years to get the data on that. And there's a prostate cancer completed and numerous others. So this is some data looking at the current trial that's being reported in Lancet on IMRT versus IMPT. On the left is intensity modulated protons, and the center is intensity modulated photons. But importantly, look all the way to the right. And that color wash shows all the extra dose given to these patients when you use IMRT compared to proton. So we subtracted the dose to the targets out, subtracted the proton dose, and that's what you have left. That can't be good. And as I said, we've all seen the toxicity of head and neck cancer with concurrent chemotherapy can be significant. So reducing that dose can be helpful, we think. So it was important to do this prospective randomized trial. And this is a trial itself. We looked at advanced patients, stage 3 and 4, and many of these patients had nodal disease, so it was bilateral neck treatments in these cancer patients. They were randomized to IMPT plus chemotherapy or IMRT plus chemotherapy. They both got 70 gray RBE when you talk about protons and 70 gray conventional radiation. They had restaging, and it was decided whether to go to surgery or not to surgery. And what have they found initially in this? Well, first I should say, it was a non-inferiority trial. There was a lot of questions early on. Were protons even as good as IMRT? If you're actually giving a dose that stops, were you going to miss microscopic disease, and these patients would actually do worse than they would with IMRT? So it was a non-inferiority trial, but there was secondary analysis looking at overall survival and a bunch of other factors, including looking at G-tube rates or getting PEG tubes, gastric tubes for swallowing issues. And this is the data on progression-free survival. You see the curve start to split out there at 81% versus 76% at 5 years. But importantly, I think the secondary analysis, which is going to be coming out, is the overall survival analysis. So at 5 years, the curves didn't split until 3 years. And that's important to know because there's another trial that's out there that was just reported early at Astro that doesn't have as much follow-up, and the tumors that were treated are not as advanced or aren't as nearly many patients with nodal disease that is being reported out of the trial in England that's coming out. But importantly, at 5 years, the overall survival rate was basically a 10% difference. That's pretty big. And much of it, we're not sure the answer why, and we think it actually has to do with the toxicity that goes with the therapy itself over time. In fact, if you look at the G-tube dependency rate for those treated with photons was much higher than those treated with protons, 40% versus 27% of needing a tube for feeding because of the mucositis and problems those patients had. Now, a lot of people say, some people say to me, G-tube, okay, no big deal. I said, yeah, big deal, because it turns out not only were there less G-tubes, many of the patients could still taste with protons because you can spare the tongue and you can spare the salivary glands. And I will say for me, I would like to go out to dinner with my family. I would like to enjoy the holidays. Meals are important to me. You look at me, I'm big. I like to eat. Meals are important to me. And if I couldn't eat and had a G-tube, that's an important quality of life issue to me. Not being able to eat, not being able to taste food. So there's going to be more trials coming out. Not every trial will be positive, but this alone justifies more than we have in centers in the United States. We can't treat all the head and neck cancers in the United States based on that data there. And some trials will be positive, some will be negative, more are going to be coming out. And for us, at the University of Pennsylvania, protons are a key strategy for a number of reasons. It's what we built now 16 years ago is a crown jewel of what we've been able to treat and do over the years. It's a world-class center. We do groundbreaking research, and I'm going to talk to you about FLASH later. We do novel combinations with immunotherapy, CAR T cells, and other things are important. We're training the world, and we see this as an important future of oncology in general. In fact, we're expanding. We now have 3 proton centers. On the left is our main center. The 2 on the right, one is in about 90 miles west of us. The other one's about 15 miles east of the center in Philadelphia. And I mentioned earlier, we're building what's called the first hub and spoke model of proton therapy. Well, what does that mean? So we have this large center. We're now building satellite single room centers because this technology was not available when we built before. We're adding single room centers in the community closer to people's homes where it makes sense for us geographically with populations. We've built 2 of these centers. The Lancaster General Proton Center opened 3 years ago, December of 2002, and the other opened 2.5 years ago. And we've seen a number of things. One, when we opened these centers, we wanted a single standard of care. We know it takes a long time to get your team trained, to get the planning at a high level, to get the physics up to snuff, to understand what you're doing, do complicated things. So we approach this very differently. We approach this with centralized planning. So the patients all get their simulation or scans locally where they're going to be treated. That information is all shipped downtown to my team that has been doing planning for over 16 years. We do the planning based on our protocols. We send that back locally, and the patients have the highest level of care close to their homes. And we're able to not do this learning curve where it took us years to do all these disease sites. We're starting with all these diseases that we do at day 1 at these sites. So their pie chart on diseases looks basically exactly the same as downtown, except for pediatrics. We only do pediatrics at our downtown site. But it looks remarkably similar, and we've taken the learning curve out of this. It's also reduced our costs. Having a centralized team, have a team of physics that supports all 3 locations for protons, and we have experts downtown that can help our local physicians and train them moving forward. So this is kind of just shows you don't have to know the numbers, but when we opened our community centers, how our volume shot up. And for the 10 years before this, we were treating about 800 patients a year. Suddenly, this year, we're going to treat 1,200 patients per year. So our volume's gone up substantially with these 2 centers. And for us, Penn, the University of Pennsylvania, is a very ROI, so return on investment kind of place. So we have to be very careful in our business plans. And the top was our pro forma that we did in 2017, looking at the number of patients we projected per year over the 3 years, and even our halo effect. And what this basically shows is that we blew this out of the water. We were so busy, and they're full within 2 years that instead of being on year 3, we should be on year 5 now at this point already. And our halo effect, which is really important, we defined the halo effect. We said it would take 3 years before we saw the halo effect because we'd see patients shifted from photons to protons and we'd have to backfill. It's not what happened. Patients all came in, we had the halo effect on day 1. In fact, our halo effect now runs between 30 and 45%. Increased volume in photons by adding a proton center, with the proton center being full. So it made a lot of financial sense. It's even blown our pro forma out of the water. And it's the 3rd time we've seen this. So we have a risk. And I tell you this now, you haven't built protons, but you have to think about the long term of protons. Our risk is we started building our center in 2006. That's almost 20 years ago. That means the computers that run our center are 20 years old. So you can imagine if you asked for a phone from me today, or your kid asked to buy a phone, and I gave them the one on the left instead of the iPhone on the right, they'd be, what are you giving me? So we need to upgrade our center. And that's actually a lot of work. When we have 1 cyclotron and 5 rooms, we actually had to bring the center down for 2 years. 2 years. So what are we doing? What are we doing with that? Well, being it's 20 years old, we're actually going to build capacity because we have 100 patients a day we're treating at this center. I got to move them someplace else. I can't shut that access down. There's no place else for them to go. My other 2 centers in the community are full. They can't go there. So we're actually building another proton center. We call it Project Atlas. Hey, it goes well with Greece, right? It's called Project Atlas. We're building 2 single-room units. Each single-room unit has its own cyclotron, unlike our 5 rooms that have one. We're going to run it 16 hours a day. So it basically, to do double shifts in each room, to take that 100 patients a day over to there while we shut down for 2 years, and then ultimately move them back. And there's a picture of the new center. It's actually under construction. It's going to open in about a year and a half from now. In fact, these were taken a couple weeks ago, these images. What you see, those are the vaults, which are the 9 feet thick or 3 meter thick of concrete. And those holes in the top are because the cyclotrons will get dropped in there. Then we'll cover that with hatches and concrete later down the road. Another learning point I will tell you about proton centers, that we made a mistake. We built our first proton center with 5 rooms. And then we built a 15-story building on top of it. That becomes very complicated when you want to replace things with this equipment. So we actually have to come through the street. We have an emergency hatch that goes through our Starbucks, which people aren't going to be happy about because we have to shut down Starbucks at Penn. So we have to come up with an idea for coffee for a little while. But I would be very cautious about building a center, then building on top of it, which many places do, because when you get to 15 years old, there's other things you're going to have to do, and you have to plan that out. It's actually very complicated. So having access is important. And this is just our schedule. We'll be opening the 2 proton vaults. One will open, we look at June of 2027, and then September of 2027, we'll open the second vault. I actually want to run the center for about a year before we shut down our current center, because there'll be bugs, there'll be operational issues we have to work out, and I need it operationally functioning very well. In fact, one of the most complicated things we're going to do is we have to move our whole pediatric population from our current site over to there, to a hospital that's never done pediatrics before. And sometimes we treat up to 20 kids a day under general anesthesia getting treated. So it's a complicated environment. It looks like an ICU some days there. You don't need to read this. I just want to let you know that these are not, facilities are not like bringing in a linear accelerator. These are complicated projects. It's like building a mini nuclear power plant. It needs a lot of work, a lot of expertise, a lot of teams. And these are just my various teams that are looking at all kinds of aspects to our Proton Center that go up to my oversight committee, which is me in leadership in the institution itself. But physics subcommittees, finance subcommittees, technical subcommittees. One thing I've learned through this, when I have committees, I have expertise on every committee that has both proton expertise and local expertise for that center that I want people to learn about protons. It also, every decision involves a physicist, a physician, and a finance person. Because every single decision we make impacts the finances, the technology, and the clinical delivery. Every single decision. And you think you're buying something, and I know what the companies say, you're not always buying something off the shelf. There's still development happening. And every decision you make is going to impact in various ways, and you want that expertise in the room when you make these decisions so you don't make a big mistake down the road that you're going to regret. And so what are we going to look like when we finish? Because this center is only about 6 blocks away. It's about a mile away from us. So we have a 5-room center at PCAM. We're going to reopen with 3 rooms as opposed to 5. I'm going to use 2 for swing space, so I can bring those up if a room goes down, or research. So we've been limited to most of our research goes on in the middle of the night. And my team would like me a lot more if the research could go on during the daytime. So we're going to reserve some research space when we have these 2 other rooms. So we'll still have 5 rooms downtown, then we'll have 2 flex rooms for research and other things. I think the thing that people underestimate most in building a proton center is the training it requires to bring a team up. The expertise to bring these up rapidly is pretty extensive. We have trained many centers in the world. I would say most centers in the world that have come up in the last 10 years, we've trained. We've trained 21 centers fully, where they've gone through our full training program, includes web-based training, on-site training at our institution. And we actually have an option. We come on-site when a facility opens for the first couple of weeks to help them through their first few patients. And you can see we've trained places all over the world, from the US to Europe to Asia, that spend time, and we have many scheduled to come in the upcoming years. In fact, if anybody's interested, we have a 1-week course. It's a really in-depth course in proton therapy. Hey, it went forward on me. It's actually going on right now at Penn, and it's full, and the next one is in the spring of next year. So if you're interested, just let us know. It's a great course. The team there this week is having a great experience. I met with them Wednesday before we flew over got here last night. So I'm going to try to bring this all around. I'm going to show a clinical case. This is my patient that explains a lot of things, I think, that I talked about for a few minutes. So this is a patient. She was, I guess, about 53 at the time, back in 2011, who I treated initially for pancreatic cancer. It was just a simple 4-field blocks approach that I treated with conventional radiation at that time. Even though our proton center was open, we weren't using it for this yet. So I treated a 4-field box approach. She was on a clinical trial with aggressive chemotherapy. At that time, it was a high dose of oxaliplatin with 5-FU-based chemotherapy, and she was really sick. She was getting IV fluids every day of the week to get her through treatment. We got her through treatment, and she did well. She had, at the time, she had pancreatic cancer, borderline resectable, and she became resectable. She went to the OR, had a resection of her tumor. Unfortunately, 2 years later, she came back with a recurrence in the celiac region, not uncommon. And this is back in 2012. And at that time, most patients she had gotten chemotherapy and her CA19-9 was rising, so she was failing treatment. And at that time, most people would go on hospice. And I said, wait a minute, she has no evidence of metastatic disease. Let's try a local therapy with protons. And this was double scattered protons, the first type you saw today, which we spread out the Bragg peak, and I treated this with protons. You can see the arrangement. I just treated the celiac region, and I treated her actually to another 50 gray. She got 5940 the first time. I gave her another 50 gray and 2 50 centigrade fractions. So yeah, it was 110 gray to certain areas of this. I spared the cord considerably. I kept this cord under 60 gray, and I retreated her. And it resolved until 2017. So 5 years later, she came back with an abnormality in the chest. And it was a growing PET-positive lesion behind the aorta and against the vertebral body. It was clearly growing. It was not we could not biopsy because of the location, but we decided we should go forward and treat this. So I treated this with actually SBRT. So with a ARC technique with SBRT back in 2017. I actually did it kind of protracted because there was data out there that, centralized SBRT could be a problem. So I treated her 400 times 15 fractions at that time to 60 gray, this area. And that disappeared. Then in 2019, she came back again, a 4th time, And this was an esophageal cancer in the exact area I treated before. This was a radiation-induced esophageal cancer from me, basically, that she came back with. So I said, well, what do I do now? So this time, I actually treated her again. It didn't overlap with the first field, but it overlapped with the second field I did. So I treated her again, but at this point, she had a lot of motion, and I couldn't treat her with protons because there was too much motion to treat with IMPT. So I treated her with a rapid arc VMAT plan. I treated her to another 50 gray in 20 fractions at this time, and this is 2019. So what happens then? In 2020, she comes up with a new esophageal cancer, not radiation-induced, in the upper esophagus. So I treated her at that point with pencil beam scanning and multi-field optimization. So it was her second protons. I treated her with, remember, I treated her first with double scattering. This is now pencil beam scanning and multi-field optimization that I treated her with in 2020 at this point. And I don't expect you to read this. And you can imagine the 5 summation plans that I was doing, looking at doses. And I will tell you, when I first did this, the first time, my team thought I was absolutely crazy. They thought I was crazy treating with somebody with recurrent pancreatic cancer. And you can't see her here. She's actually in the middle of this photo. This was this spring. So from original treatment in 2011, she is doing fantastic. She's the one with the polka dot shirt, like 2 people in, behind the person in the very blue one. I was actually texting her this morning because she had a scan yesterday, which I read before I came here. It was all clear. So she's cured. And I think there's a lot of important points here, right? That I used 5 different tools, 5 different therapies in her over the years. Conventional radiation, SBRT, 2 types of protons, VMAT, because they were appropriate for the different circumstance she was in. I didn't have protons and I treated them all protons, right? I had a tool and I pulled it out where it made sense for her. That's the power that protons brings you. When you bring it with conventional radiation, that you can bring it in optimally. I didn't push it when she had motion to use protons. I used VMAT. You have to be a good radiation oncologist. You have to think out what you're going to do. But that's the power of protons. So in summary, I think protons are an exciting modality. They're clearly spreading nationally. There's lots of interest in combining protons with chemotherapeutics, biologics, immunotherapy. Single-room centers have changed the entry point. They've changed the cost. So you're seeing more of these centers and acceleration of these centers. There's going to be a lot of clinical trials reported in the coming years. I'm thrilled with the first head and neck trial that will be published any day now in The Lancet. These are complicated projects. They require a lot of learning and teamwork and take years to see through to fruition. And I think, importantly, investing in education, investing in your team is critical to bring a proton center up effectively. And I'm going to talk about flash, and there's more to come. So I'm excited about protons. I'm really excited about the world's going with flash. And we'll talk about that a little later. So thank you.